Just before we get started, I'm a physician. I've also got a pathology degree. I run a large menopause clinic that's the headquarters, if you like, is based in Stratford-upon-Avon. And we see a lot of people. It's a private clinic because I couldn't set up in the NHS 5 years ago when I tried, because menopause still isn't really a priority for people. But I don't work with any pharmaceutical companies at all, and I'm really clear about that because a lot of doctors, especially in the menopause space, do, and I don't. So the work I do is impartial and evidence-based. I do have one sort of declaration, and that is that I take HRT. And I'm quite open about that for many reasons. The main reason is that, firstly, it took me quite a few months to realize what was going on. I just thought I wasn't very capable of having 3 children and being a GP and trying to run a home. And my life sort of fell apart for a few months, really, and I was quite close to giving up my job until my 12-year-old said to me, "Mummy, you're really cross and angry. Perhaps a period might make you feel a bit better." Some of my friends feel better after they have a period. And then the penny dropped, and I realized that I still loved my husband, even though his breathing was annoying me. And I could still have my brain working again, but you know what? Without my brain, it was really difficult to work. I couldn't remember things. I couldn't remember patients. I couldn't remember drug names. I was also really, really tired. But the worst thing about this is that I can't get HRT from my GP. The dose I'm on, the type I'm on, I also use testosterone. My GP won't prescribe it for me. Now, I'm a white, middle-class, healthy, educated, English-speaking woman. If I can't get HRT, what, for a lot of your clients, I have no idea, but I'm sure it's not going to be very good. So Stratford-upon-Avon, Shakespeare's birthplace, we're trying to knock him off and become the menopause capital of the world. But our clinic is more than a clinic. I listen to stories every day that make me very sad, of women who are really struggling to be listened to be heard, to receive treatment as well. So a lot of our profits we put back into other things as well. So there's a lot of other work that we're doing. Some of it's behind the scenes I don't talk about, some of it is, but it's all trying to impact people in as many ways as possible. And I've been a medical writer for 25 years, as well as a GP. So a lot of my knowledge of evidence-based medicine is put into various platforms. And lots of booklets, lots of information. Hopefully we'll be developing one for people with head injuries as well. The app I developed out of frustration because I wished I'd had it 8 years ago rather than struggling on my own. So people can monitor symptoms, have information, track their periods if that's what they're having. And we've had over 1 million downloads globally of the app, which sounds impressive, but there's still lots of people that aren't accessing it. This is a quote which came from a McKinsey report, and I think it's absolutely true that there is a moral imperative to address the women's health gap and improve the lives and livelihoods of billions of women worldwide. And I'm sorry I'm only talking about 50% of the population, but you could argue the other 50%, i.e. men, actually do need women to function well. So I thought I'd bring it to life, just so you know, Chair, this lady wasn't called Laura and she didn't look like this, but this is absolutely true, what happened, and I just thought it might resonate a bit, really. So this lady, when I saw her in the clinic, was 42, and she'd had a brain injury 15 years previously, which had affected her in many ways. She had carers, she was mostly independent, but she still needed help. And her carers and family had been quite worried about her behaviour. They said for the past sort of 6 to 9 months, her sleep had been poor, she was anxious, her mood was low. She was more argumentative as well, and they'd noticed that she'd started to self-harm, which was something that she hadn't done before. She was more frustrated, she didn't want to socialise, she didn't want to go out with people. They weren't really sure what was going on because she hadn't really been like this before. She'd been to see her doctor and they thought, well, maybe she's depressed because of some of her mood changes. And they gave her some sertraline, quite a standard antidepressant, but it didn't really help her mood. They added in metazapine because her sleep wasn't very good. And they think that her sleep improved a little bit, very hard to tell. But her anxiety worsened, her behaviour worsened, so didn't really know what to do. She also had headaches and migraines, but they'd become more severe, more frequent, and so they were concerned about that. Her memory seemed to be worsening as well. She didn't have such good recall for things, and she also was constantly tired, even though her sleep seemed to be better, but they thought maybe it's side effects to the mirtazapine. She had no self-motivation, also was complaining of some stiffness and pain in her muscles and joints. And she was also getting quite a few recurrent urinary tract infections. And many of you know if someone has a UTI, it can affect them cognitively as well. So a lot of her symptoms were put down to her urinary tract infections, although she did have quite a lot of treatment, obviously a lot of antibiotics as well. She was getting some incontinence, but again, she'd had a brain injury in the past. Could it be related to that? It's very easy, isn't it? When someone's had a brain injury, you just blame everything on the brain injury, and you forget that they could have other things going on in their body. So she was given medication, she was given painkillers, she was given some quite strong anti-epileptic drugs, actually, for her migraines. But that really didn't help, and she's very limited by balancing side effects. Obviously, lots of antibiotics for her urinary tract infections. And then she had lots and lots of tests for these different different symptoms. So she also, as well as having the tests, she was also seeing lots of specialists as well. But all these tests came back normal, nothing else, which the doctors had great delight just saying absolutely fine. It wasn't very good for her and her carers because she had no idea and knew something was going on. So reassurance, but actually this is about listening to the person, and things weren't right. And the carers did say, and she'd agreed as well, that her periods were much more heavy and more frequent. So she's 42, her periods are changing. And so they were thinking, I wonder, could any of it be related to her hormones at all? And so they did ask a few times some of the myriad of healthcare professionals they'd seen and said, look, this can't be anything to do with your hormones because she's still having periods. And also she's never had any flushes or night sweats. I hope you realise that isn't accurate. But also, this is the other thing, which is not just with this patient. I have heard so many times, she uses a wheelchair, so anyway, you wouldn't give her any HRT anyway, so it doesn't really matter. And that is absolutely incorrect. So what is her diagnosis? It's not rocket science. I've come here to talk about menopause, but she's not menopausal because she's still having periods. So she's perimenopausal, the time when hormone levels fluctuate and change and periods are still going. And also, she might have clinical depression. You are allowed to have 2 things wrong with you, or 3 or 4 or 5. But we can't just look only in one area. So what could have been done differently? And I'll come to her at the end of my presentation. We've got some really good guidelines about menopause care. Actually, the NICE guidance are quite old now. They were developed in 2015, and there's still a bit of discussion with the draft updated ones. But we've also got guidelines on shared decision-making, which is really important for anything I do as a clinician. But if we think about menopause, even the word really frustrates me. And it frustrates me because it doesn't really describe what it is. If you break down the word menopause, it just means a stop in the periods. But somebody somewhere, and I don't know who I'm trying to work out, decided it was a year since a woman's last menstrual period. I absolutely have no idea what happens exactly a year after our last period. But also it's really frustrating as a clinician for me to have to wait a whole year. So if someone comes in after 11 and a half months of not having a period, do I turn them away for 2 weeks and say, sorry, I can't diagnose you? Like, we don't want to have this retrospective diagnosis. We want to help people at the time. And then some people don't have periods. They might be using contraception. They might have had a hysterectomy. So do they not become menopausal? It's difficult, isn't it? Or some people say, well, it's the end of a woman's reproductive age. And in some cultures, that's really difficult to deal with. But also women who are young, so around 1 in 30 women under the age of 40 have an early menopause at a younger age. They might still be fertile and their fertility might improve with hormone treatment. So it's not actually, that's not an accurate description either. Also, if we only focus on menopause, we're forgetting Laura, we're forgetting the perimenopause, but also we're forgetting any hormonal changes, so PMS, PMDD as well, and even postnatal depression is likely to be related to the changing hormones. So what's really happening in our body is that 3 hormones, we've got hundreds of hormones, but just 3 that are produced by our ovaries, estrogen, and I've put in brackets estradiol, which because it's the nice type of estrogen, progesterone and testosterone. So these are hormones, they're chemical messages that affect every cell in our body. They come from our ovaries, but our brain produces them as well. If there's only one thing you learn in this conference, please learn that these 3 hormones in men and women are produced by our brains. They are neurosteroids. It's not just about our ovaries. So the WHI study was this awful study that made people very scared of hormones for the wrong reason. So playing with words, instead of it being the Women's Health Initiative study, we need to think about women as the menopause as a women's hormone insufficiency. Because if we think about an insufficiency, then we think about what's the problem. If someone's deficient in something, you think, how do I replace? And all of these conditions, PMS, PMD, perimenopause, are related to hormones. And if you think about brain injury, we've already heard some people might only transiently lose their periods. And so you might think, oh, it's only a few months without a period, but it's a few months without hormones, which have a really important role in our brain. And it's a massive problem, menopause. Like I've said, it affects 100% of half the population. So we can't keep ignoring it. And if you look at the scale, actually this figure's slightly wrong. I was trying to work out including younger women, and it's more like 1.3 billion menopausal women, and we need to be listened to. There's lots of us around, but the sad thing is a lot of people are struggling to receive the right advice, support, help and treatment. And this is some study we did a little while ago, but I don't think it's going to be any different if we repeated it, that many people are going back and forth to their doctors, like indeed Laura was, before she was given any help or advice or even a diagnosis. And around 1 in 10 women have had to wait 5 years for treatment. We know women who are young with premature ovarian insufficiency can take about 8 years to get the right diagnosis. And every day I speak to women who have been told they're too young, they're too old, they're too something else. And it's not, anybody can have it. My youngest patient became menopausal when she was only 12. Because her periods didn't develop properly. Her ovaries didn't develop properly. Another of my patients was 14. She had a cancer in her thigh, and the radiotherapy and chemotherapy stopped her ovaries working. So these two, when they were menopausal, they were both in classrooms, sitting in double maths, finding a lot of discomfort and irritation, but also had a lot of brain fog. And then they were just blamed as being troublesome teenagers. We have to be thinking more about younger people too. These are some very basic posters I'm going to show you, showing just the importance of estrogen, progesterone and testosterone throughout our body. But estradiol is affected in around 1,000 at least cell processes. They're biologically active hormones that reduce inflammation. They help our cells to work. Even some of you might have heard of mitochondria. They help the mitochondria work. They help all our cell processes work. And there's no surprise they have this massive impact, but especially through our brains. Really important when we're thinking about what we're learning today. And progesterone. Many clinicians have been told progesterone is just for the lining of the womb if a woman's on HRT. But actually it helps with our brains. It helps improve the synapses. It helps improve the neurons to develop. It's also so anti-inflammatory that one of the first things that our brain does if we have a brain injury or a stroke is to produce progesterone. The brain produces progesterone. And I would love some research into this, because wouldn't it be great if we were thinking about giving progesterone to all people, men and women, who have brain injuries, because that's the normal response. But everyone's just been so scared about hormones, they've been ignored in any data and studies. And testosterone is the most biologically active hormone. Very interesting, because we heard earlier about doing FSH levels and estradiol levels, but nothing about testosterone. And women produce more testosterone than estrogen when they're younger, and levels decline with age. But if the ovaries aren't working, the levels will decline a lot quicker. And increasingly in the clinic, we're seeing a lot of women who are more testosterone deficient than estrogen or progesterone deficient. Really, really important for our brain. So how do we diagnose it? It's all very well knowing about it, but how do we diagnose it? Well, firstly, there isn't a good blood test. I'm really sorry to say. Even the FSH, the follicle stimulating hormone test, is not accurate. The guidelines say we should be doing it in women under the age of 40, but I have seen hundreds of women who have normal or low FSH levels. And certainly if there's a brain injury or if they're on a drug such as an antipsychotic like quetiapine, that will alter and suppress FSH. Drugs that increase prolactin will suppress FSH. So people might have a low FSH leading to a low estradiol and testosterone and progesterone, or it might be normal. Or in the perimenopause, hormone levels really fluctuate. So you might do a blood test at 3 in the afternoon and it be normal. At 3 in the morning when the lady's waking up with a night sweat, of course her level's not going to be normal then. So they can be very, very misleading. So often I don't do them. So the diagnosis is often in the history. If people are given information, we can ask the right questions as clinicians, but as perimenopausal or menopausal women, we can work it out ourselves. So on the Balance app, there's a symptom questionnaire where people can monitor symptoms and have a look. And then it's a lot easier to go to the doctor and say, these are my symptoms, I would like to talk through them and I would like to talk about treatment, rather than the doctor having to ask, have you got this symptom or what have you. And this is just a symptom questionnaire. It actually doesn't contain as many symptoms as it should. This is a questionnaire that was developed in 1976 by a male gynecologist who I think saw about 3 patients a month and decided these were the commonest symptoms. So we're just redesigning a bigger questionnaire. But I think for anybody who's involved with females should be thinking about the symptoms, and I'll explain more of them, but could any of the symptoms be related to her hormones? And if not, why not? We shouldn't be using every excuse to thinking, oh, it's because she's got a brain injury, because she's got depression, because she's got another condition. We should be actually spinning it around and thinking, why could it not be related to her hormones? And also just think about hormonal contraception, because they're synthetic hormones. So they actually block natural hormones working. So a lot of people, for example, who've had the implants, very convenient, they don't have periods, but it's blocking estrogen, it's blocking testosterone, and blocking natural progesterone as well. So it's almost giving people a chemical menopause. Some people are fine, but a lot of people have symptoms with synthetic hormones. It's worth even making a note, have they had a hysterectomy or their ovaries removed? Because even if their ovaries are still there, they're likely to be menopausal at an earlier age, and some people forget to tell us. There are so many symptoms, and every day I learn about more symptoms because people tell me about them. This is a word cloud that I made, just looking at, this is a symptom questionnaire we did on nearly 6,000 perimenopausal and menopausal women. And the larger words or the larger font are the more common symptoms. And you'll see most of them are symptoms affecting the brain. But not everybody has every symptom. Some people might have a few. Some people find that their symptoms might change with time. People talk about the average duration of symptoms as being only 7 years. That's quite a lot in my life. But actually, I've seen women who've had symptoms for decades. Or I've seen people that have only had 1 or 2 symptoms. I saw someone a few months ago, her only symptom was tinnitus, ringing in the ears. So she'd been seen by an ENT surgeon, a max fax person. Everything was normal, but she thought it could be her hormones. I gave her some HRT, and 3 months later, she was absolutely fine. But she was very close to taking her life because she couldn't sleep. She couldn't do anything. The ringing in her ears was so awful. So you don't have to have a certain number or a certain frequency, or they last a certain length of time to make the diagnosis. Symptoms affecting the brain are, without a shadow of doubt, the most common perimenopausal or menopausal symptoms. And if you'll see in this study or this survey, 96% of people had brain fog, but also anxiety, low energy, memory problems, sleep, low mood. And of course, people can get those symptoms for other reasons as well. The flushes and sweats, which everyone thinks are related to menopause, in this survey only affected 68% of people. So this is a very simple picture of a brain, but I wanted to just highlight where most of the cells are that respond to estrogen, estradiol, the nice estrogen, and also testosterone. I've already said they work all over the brain, but there are certain areas of our brain where we've got a higher concentration of the cells that respond. Some of you might know what some of these areas do, but essentially a lot of these parts of the brain, they work on our memory, on our mood, on our personality, on our sleep. Our hypothalamus we've heard of before, but there's a temperature control as well, but also our control of respiration rate and our heart rate, even the way how we digest and metabolize food as well. And the cerebellum is our coordination as well. Lots of people find that they drop things, that they're just a bit more clumsy when they're perimenopausal and menopausal. And our brains obviously like homeostasis, they like everything the same. So you can imagine in the perimenopause, when hormone levels are really fluctuating, our poor brain doesn't know what's happening. And you can understand when people are menopausal, so their hormone levels are low, then these low hormones just don't light up the brain. They're not there. Other hormones might take over, the brain will accommodate and change, but it's not going to work in the same way. You're not going to have the same glucose metabolism and reduced inflammation in the brain without these hormones. Testosterone, I've already mentioned. There's lots of symptoms associated with testosterone deficiency. And again, it can be very difficult to tease out whether they're related or not. And a lot of people say to me, I know none of these symptoms can be due to my hormones because I'm on HRT. And then we talk to them and they're not on the right dose of estrogen and they're not on testosterone. So until their hormones are completely optimized, you can't say whether their symptoms are related or not. We know really reduced libido is associated with low testosterone, but if we think of Freud's definition of libido, it wasn't just about sexual pleasure, it was pleasure of life. And a lot of people say to me, they're just existing, they're not living, everything's in black and white, the joy from life has gone, and that's often because of the testosterone. Symptoms affecting the gastrointestinal system are really common as well. So weight gain can be common, and one of the reasons for that is that our fat cells produce estrone, which is a very inflammatory type of estrogen, but it's all the body can have. And so it's often in the midline that people tend to put on weight, and there are metabolic changes that occur without having estrogen in our body. And then a lot of irritable bowel type symptoms can occur, so bloating, wind, constipation, heartburn can be very common as well, all related to our hormone receptors lining our guts and also affecting our gut microbes as well. Mental health as well, really, really common. So 80% of people in this survey anxious or stressed, more overwhelmed, very tearful, irritable, and also just feeling very flat. You can see why people are given antidepressants. Many surveys I've done have shown at least 60% of women have been offered or given antidepressants. Since the WHI study, the rate of prescribing for antidepressants has more than doubled in women. It's just awful. Genitourinary system. Everyone thinks periods just fade away and then stop. But actually, for a lot of women, they become heavier and closer together. Urinary symptoms are very, very common, and we have to remember that urosepsis kills about 1/3 of people who die from sepsis. It's a very, very common cause of death, and we know that having local hormones can reduce that. So if anyone is having urinary tract infections, it's not just because they're a woman. We need to think about their hormones. And this is really important to think about. Lots of people think, HRT is just a lifestyle drug, it's just used for nice skin and hair, which is absolute rubbish, by the way. But actually also, if people are noticing their skin is becoming dry and itchy, their hair's changing, they're losing hair, the texture of their hair's changing, then it shows that there's something physical going on. For many, many years, decades, century, women have been blamed that we're just a bit hysterical, we just a bit can't cope with things. But actually, we can't make up our dry skin or our hair changing. So if anybody has these changes, we need to, again, to be thinking about hormones. So as a clinician, obviously, I went into medicine to help people feel better, and I do in my clinic, and it's lovely. But actually, there are risk of diseases. Our hormones are very anti-inflammatory. If we don't have them, then we have diseases. But women are more likely to have diseases, as are men, as we age. Aging population is a huge thing because we're living so much longer than we used to. But these are the main diseases that affect women. And actually, we know most women actually die from heart disease and dementia. That's the commonest causes of death. But there are others as well that are creeping up, as we know. But there are diseases associated with menopause. And it's no coincidence they're exactly the same diseases. And so we need to be thinking of this long-term hormone deficiency with health risks, because then it will make us think a bit more about what should we do about treatment. And I'm sorry this has been so doom and gloom so far, but there is treatment. The most important thing about treatment, in my mind, is about information. So people can have a choice. They can be aware of what's going on and then decide what's right for them. Having more awareness that it's more than just hot flushes. This is a booklet that we wrote with dimensions for people with learning disabilities. Information about clots as well. You remember Laura was told she couldn't have HRT. And I do a weekly podcast, and I managed to do one of my podcasts with somebody, Sharon, who had learning disabilities. It was quite hard because she was signing a lot, and I kept saying, Sharon, they can't hear you if you just sign. You have to talk as well. And this lady had a spinal injury. Really important that these people have a voice, actually, and can help others. 3 letters, HRT, has caused the biggest scare for any other treatment ever in the history of medicine, I think. And this is because a study came out 20 years ago saying there was an increased risk of breast cancer. The types of HRT we prescribe now, we're very fortunate. They're so-called body identical, so biochemically, they're exactly the same as the hormones we produce ourselves. They're not made of pregnant horses' urine, they're not synthetic, they've never been shown to be associated with a risk of breast cancer, and estrogen has been shown to be associated with a lower risk by about 22% of breast cancer. So we're very fortunate, and we usually prescribe estrogen, progesterone, testosterone separately so we can give the right dose and type to the right person. And there are benefits of taking HRT. Firstly, it improves symptoms because we're replacing what's missing. So if the dose is right, the type is right, people feel better. And we know from all the evidence, all the guidelines, that for the majority of women, any risks are far less than benefits. And for most types of HRT, there aren't any risks. It's just our natural hormones we're giving back. Not just it improves symptoms, actually, it reduces the risk, and this is exactly the same list of the diseases that are affecting women's health and affecting menopause as well. And you would think, therefore, if the guidelines that are 8 years old are saying the majority of women should be taking HRT, you'd think most of us would be taking it. But actually, it's about 14% of women in the UK. But in areas of deprivation, it's as low as 2%. We've got a huge long way to go. Globally, it's 5% of women are receiving an evidence-based treatment that will help them feel better and improve their future health. We think about clot risk and HRT. We know that if people have a tablet of estrogen, it gets metabolized in the liver. There is a small, but there is still a risk of clot. But we don't have that. If we use estrogen through the skin as a patch or gel, it goes straight into the bloodstream, there's no risk of clot at all. And in fact, some of the data show it's probably got a lower risk of clot. The vaginal hormones, absolutely fine. They don't get absorbed in the body. The natural progesterone, no risk of clot at all. I'm sorry to talk about vulvas and vaginas before lunch, but vaginal dryness, soreness, irritation affects around 80% of menopausal women. It's a symptom that's progressive with time, yet only around 8% will receive any treatment. But it's not just the vulva, the vagina, it's the surrounding tissues, and it's not even just for sex either. A lot of women find sitting down for long periods of time. I see quite a lot of women that can't wear underclothes, they can't wear jeans, they can't exercise because there's a lot of discomfort because the tissues become very thin. And I've already mentioned all the urinary symptoms too. There's treatment for that, which is not the same as systemic HRT. It's vaginal treatment, so there's a vaginal pessary, there's gel, there's cream, there's a little insert of this ring down here, which is really good for people that are disabled because someone can insert that ring and it's a slow-release estrogen. It lasts for 12 weeks. I used to use it a lot for patients with dementia. So we're very fortunate. Even women who've had breast cancer, women who don't want to take systemic HRT can use these very, very safely. So before I end, just to go back to Laura, I gave her HRT because she was perimenopausal. She was experiencing symptoms, and with a lot of patients, I say, I have no idea how many of your symptoms are related to your hormones, but I know that HRT is safe, and actually I know that giving you 3 months is very safe, and we can just try, and then we can review. So I gave her HRT, and I also gave her some vaginal hormones as well, to try, because I was worried about all her recurrent urinary tract infections she was getting. And unsurprisingly, after 3 months, her symptoms had improved. She had no more UTIs, and we know that vaginal hormones can reduce recurrent urinary tract infections by about 50 to 60%. It's not insignificant. But her behaviour was better. She was also, the carers found it was transformational. They said this is the best she's been for many years, actually. They hadn't realised how bad she'd been because a lot had been so gradual. So take-home messages, really, is that firstly, it is a clinical diagnosis. So it's fine to recommend blood tests, but actually they're not going to pick up perimenopause and menopause. We should be thinking more about it. We can ask people about their periods, of course, but if they don't have periods, then they're not on contraception and they're not pregnant, of course, then we need to make the diagnosis of menopause, especially in younger women, because we can't deny these women treatment. Symptoms can be debilitating. Some women seem to breeze through, but not many actually when you really talk to them carefully. We need to remember that hormones are safe. They are one of the safest medicines I've ever prescribed as a doctor. And there are future health benefits as well. So we're not just taking HRT to feel better, we're trying to improve our future health. And a lot of people, when they take HRT, they can then actually start thinking better about their nutrition and their lifestyle and everything else too. So it's a combination approach. So I know that's been quite a lot of information, but I promised that I would have 5 minutes at the end for some questions. So that's just a QR code if you want more information. So thank you very much.
Thank you very much, Dr. Newson. Unsurprisingly, we've got lots of questions, and we're not going to get through them all today, but I wondered if you had time for a couple. And yeah. Dr. Newson has kindly agreed to attend a webinar at a later date to address some of the common questions, which is very kind of you. So a couple that have been liked, so I'll raise them. How do we agitate to get menopause up the medical agenda and increase availability of the right treatment and medication to meet individual needs?
I wish I could answer that really easily. It's something that I think about every day, how we do it, and I think it's a joined-up approach, actually. It's about trying to educate, and I think trying to forget menopause and think about hormones is really important. Actually, educating people about the risks of not taking HRT, which is really important, especially for many groups of women. But it's a massive problem because it's about women, it's about hormones, it's very cheap, we haven't got Big Pharma behind us. Big Pharma don't want women to take HRT because otherwise they'll be, women who take HRT don't usually take antidepressants, they don't normally take blood pressure treatments, they don't normally take statins, they don't normally take painkillers. So there's lots of agendas that need addressing.
Thank you. Another question. Is it true that GPs are less inclined to prescribe testosterone and only usually prescribe estrogen and progesterone as HRT? If so, how do we tackle this?
Yeah, it's really difficult because some GPs aren't allowed to prescribe testosterone. It depends on their formulary in their practices. We're all independent prescribers as GPs, but we are dictated to depending on where we live, so some people don't. The biggest problem is about education for healthcare professionals, not just GPs, for all specialists. I was up in Edinburgh last night getting a prize for a course I've written for mental health and hormones for the Royal College of Psychiatrists. And they're saying, this is great, we're having this conversation, but no psychiatrists in the UK prescribe HRT. Like, it's ridiculous. So, but I've spoken to the Royal College, because I'm a fellow there, about the lack of testosterone prescribing, and they said, the problem is, Louise, it's your media attention. If you stop doing your media work, women wouldn't be coming to ask for hormones to the detriment of other patients. So we've got quite a long way to go to understand, and it's also some of the societies say that testosterone can only be given if women are severely psychologically distressed with their reduced libido, and it has to be at least 6 months. I again find that quite insulting as a woman to have to even justify that I'm so severely psychologically distressed, and libido isn't just about sex. And I've spoken to a lot of doctors who say, well, she's not sexually active, therefore she wouldn't benefit from testosterone. It's just a natural hormone.
Thank you. And last one, have you worked with women in early menopause directly due to traumatic brain injury? Does this change the nature of symptom management? Who should they see?
So it's a really interesting, difficult question because I'm not aware of any good quality research. We do know that people that have trauma are likely to have an earlier menopause. Anything that affects our brain, our bodies are very good at switching off. They don't want us to get pregnant if we've got extreme stress or illness or whatever, and I'm sure it's probably the same with many head injuries as well. And it will, if it disrupts the hypothalamus, of course our sex hormones, that whole axis will go. What we need to do is aware and then be advocates for our patients as well. And it often takes more than one healthcare professional to receive the right information and advice. But it's really important because then you're setting up these women for really important health gains going forwards.
I think we might have time for one more.
Okay.
Sorry to keep you. So once on HRT, how long should you take it for? Will symptoms return if you stop taking it?
Yes, it's a good question, isn't it? So a lot of people think that we can only take HRT for a few years, and sometimes this is because people are worried about this breast cancer risk. Older types of HRT with the synthetic progestogens, so as I've already said, estrogens associated with a lower risk of breast cancer. Synthetic progestogens is small but not statistically significant increase. Even the worst study actually shows that women have better outcomes when they take any type of HRT. So we don't need to stop it after a certain length of time. The guidelines are clear. We just follow people up. Every year we just review, do the benefits outweigh the risk, carry on. So most of us take it forever because if I stop my HRT today, which I'm not going to, then my bone turnover will increase. My brain will not be lit up so much. I know even if I forget to change my patches for a couple of days, my migraines come back. So we know that it can improve symptoms, but also I might not have any symptoms. My body might adjust to not having hormones, but my bones, my brain, my heart won't. So we know that the longer term health benefits are there. Older women can still take HRT. Older women can start taking HRT because it's so safe as well. And if we think even just osteoporosis that affects 1 in 2 women over the age of 50, it's really important.
That's great. Thank you very much for your time, Dr. Newson.
Thank you.